patient. Okay, so if you have read and understood, considering the critical care scenario, kindly please tell me, how would you manage this patient now?
Okay, I will manage this patient according to CRISP protocol. First, start by check the airway. It's patent and then check breathing. I will check. I will check the respiratory rate and respiratory pattern and equality. And then I will check circulation. I will check the vital signs, blood pressure and heart rate and the pulse.
Yes. What more would you do, please?
What?
What more would you do? What measures would you take? Patient has, yes, desaturated, oxygen saturation.
Yes,
has dropped,
I will.
Yes. Yes. How?
I will get the patient. Then before I check the circulation, I will give the patient high flow oxygen.
Okay.
15 liter per minute, and then I will go for circulation. I will put the patient to wide pore cannula and insert a urinary catheter. Then I will start fluid challenge.
Kindly comment. Patient has been given 7 liters, out of which 4 liters were normal saline. Is the amount of fluid given to the patient is required or more? Comment, please.
No, I think it's overload. I think it's a volume overload.
Okay. How would you identify, or how would you make sure that patient has been given overload fluid?
I will check the fluid chart of the patient. Yes. And see the input and output and see the difference.
Yes.
Then I will check.
Yes,
I will check the central venous pressure.
Yes. Yes. How much should the normal central venous pressure be?
It's between 8 and 10.
Okay.
Millimeter mercury.
This patient was given furosemide but still has become oligouric. Can you explain why?
I think because the renal perfusion.
Yes. Acute renal injury.
Yes.
And?
Okay, I will come to this back later.
All right, good. So if in this situation, how would you confirm your diagnosis? What investigations would you ask for?
I will withdraw bloods.
Yes.
Like
yes.
Yes, and the ABG.
Yes, good.
And
maybe ECG as well. Yes.
And ECG.
Yes.
And I will go for a chest X-ray.
Yes, very good. So just suppose you've done the chest X-ray. No, I don't have it with this one. I'm sorry. So just suppose you've done the chest X-ray and it has come back. What do you expect to see in it?
In chest X-ray, I will see the B curly lines and the prominent vasculature of the upper part of the lung, and maybe pleural effusion in the costophrenic angle.
Loss of cardiophrenic angle, and there could even be cardiomegaly because you're saying overload, so that could also be there. Okay. If you can tell me what do you understand by the term preload reduction?
The preload is the volume of the blood at the end of the diastole in the ventricle.
What are the medications which are causes reduction of the preload?
The medication that reduce the preload.
Yes. Do you think furosemide is one of them?
Yes, because it's diuretic and
yes,
it decreases the blood volume. Yes.
Yes, very good. Any other example that you can think of? Yes. Nitrates.
Nitrates,
or
yes.
IV morphine sulfate. Okay. Do you think since the patient is post-operative, patient could be on a high risk of myocardial infarction?
Yes.
How would you confirm that?
By ECG.
Okay, very good. What is the normal output which can be classified as oliguria?
If it be less than half milli per kilogram per hour.
0.5 ml, yes, per kg per hour. Okay, very good. Can you explain or can you give me few indications when a patient can become oliguria? Few examples or indications or conditions that you know of in which patient can become oliguria?
There are many causes. There are pre-renal causes.
Yes.
And renal and post-renal.
Very good, yes.
The pre-renal is like hypovolemia and shock. The renal is like this case acute kidney injury, and post-renal may be because of obstruction and like stone or a mass compressing from outside.
Yes, good.
Like prostate cancer or
yes. Considering patient was given out of 7 liter, 4 liter of normal saline, do you comment on the choice of the fluid which was given to the patient? Was it the right choice of fluid to give it to a post-operative patient?
No, because it's a hypertonic.
Okay. What should have been the ideal fluid to be given to the patient?
The isotonic saline, like Ringer lactate.
Okay. Good. Can you tell me what would be the sodium concentration in Ringer lactate or Hartmann solution?
Oh, okay. I will come to this back later.
Okay, yes. Where should this patient be managed?
In the high dependency care unit.
Very good. Who would you involve in the management of this patient?
I will inform the consultant of the case, and I will inform the ITU registrar.
Yes.
And the cardiologist.
All right, good. Last question. Can you please explain the process or how does it go about when there is low urine output because of low cardiac output? How does it lead to that? Low cardiac output leading to low urine output. What is the mechanism behind it? How does it?
I can't. My connection is lost a second. Can you repeat the question, please?
Can you please explain the connect between low cardiac output? How is it related with the low urine output?
when the cardiac output is low, it will affect the renal perfusion. It
Very
will
good.
be low
Yes.
also.
Yes.
So the glomerular filtration rate will be low, and
Yes. Stroke
and then
volume will be
the
yes.
yes, and the amount of the amount of the amount filtered from the blood also
Yes,
will be low,
will be
and
less. This will activate RAS.
that
Yes.
yes, that will activate
Yes.
renin angiotensin aldosterone system. Yes.
System. Very good. This is actually I wanted to hear from you because of decreased cardiac output, there will be ischemia, and this system will be activated. And what else? 2 other hormones you can tell me.
Yes, aldosterone and antidiuretic hormone.
Very good. Thank you.